Afternoon, everyone, and thank you so much, Dr. Richer, for sharing all your knowledge and your clinical wisdom with us this afternoon. So I'll go ahead and go over the most recent guidelines on the aorta management of thoracic aortic disease, with a specific focus on genetic disorders. So I do not have any disclosures for this presentation. And this is our outline for the session. So we will start with a brief overview of epidemiology. So thoracic aortic aneurysms occur in 5 to 10 per 100,000 person years, and approximately 20% of those are genetic or heritable. And up to 20% of individuals with a thoracic aortic aneurysm or dissection have a family history in at least one first-degree relative. So we can divide thoracic aortic aneurysms into two broad categories, that is sporadic aneurysms and hereditary thoracic aortic disease, or HTADs for short. HTADs can be subdivided into syndromic and non-syndromic disorders, the former being associated with multisystem features like we reviewed with Dr. Richer. Some risk factors for hereditary thoracic aortic disease are listed here, and we've already reviewed them with Dr. Richer, but basically thoracic aortic disease with syndromic features, presentation before age 60, family history of thoracic aortic disease or peripheral or intracranial aneurysms, and also a family history of unexplained sudden death at a very young age. Before reviewing the 2022 guidelines, I will quickly present the size thresholds from the 2014 CCS guidelines on the management of thoracic aortic disease. As you can see here, these are the numbers, and I wanted to point out that Loeys-Dietz, Turner syndrome, and Ehlers-Danlos syndromes were all amalgamated and shared the same surgical thresholds back in 2014. And since then, our knowledge on genetic aortopathy has grown considerably. And as you will see, we now have new recommendations specific to almost every single one of these syndromes and even specific genetic variants. All right, so we will now dive into the 2022 guidelines, starting with recommendations on genetic testing. So genetic testing is recommended for individuals with syndromic features, those with a family history, and those with an early age of onset of disease. Thoracic aortic imaging is recommended for first-degree relatives of all individuals with thoracic aortic disease, regardless of age of onset, to detect asymptomatic aneurysms. In cases of positive genetic testing, that should trigger a gene-based management of the patients and what we call cascade testing of at-risk relatives. And I will review what cascade testing means. So in patients with thoracic aortic disease, it's recommended to obtain a multi-generational family history, specifically with regards to sudden deaths, aneurysms, including aortic aneurysms and peripheral and intracranial aneurysms. In addition as well, patients with risk factors that we just discussed, risk factors for hereditable thoracic aortic disease, genetic testing is now recommended as a class 1 level of recommendation, which is also new from the 2022 guidelines compared to the previous iteration in the 2010 ACC/AHA guidelines. So the most current hereditary thoracic aortic genetic testing panels include 11 genes, which are listed here in red. And these 11 genes are confirmed to confer a very highly penetrant risk for thoracic aortic disease. We will discuss some of these genes more specifically later on in the presentation. With regards to genetic variants, they are categorized into 5 categories. We have benign, likely pathogenic, and variants of unknown significance. So variants of unknown significance are, as the name implies, not confirmed to cause a thoracic aortic disorder, and should not be used to either identify family members at risk for aortic disease or guide clinical management. With regards to recommendations on genetic counseling, it should be provided to patients whose genetic testing reveals a pathogenic or likely pathogenic variant, and the clinical management of these patients should be informed and by that specific pathological variant. And I will give specific examples. So here you can see, again, the 11 genes that are part of our genetic panels. And nowadays, with more recent data and more clinical characterization of these genetic variants, we know more about not only how to identify family members at risk for hereditary thoracic aortic disease, but also we know more about which specific aortic disease presentation is associated with a certain gene. For example, is it more aortic dissection or more aortic aneurysms? We also know the risk of dissection for specific aortic diameters, depending on the abnormal gene. And we also know whether these patients are at risk for other vascular disorders. For example, patients with a mutation in the gene TGFBR2 are predisposed to thoracic aortic aneurysms and dissections, but they are also at risk for intracranial aneurysms and dissections of other peripheral arteries. Whereas in contrast to this, mutations in the ACTA gene lead to thoracic aortic aneurysms and disease, but also occlusive vascular disease, for example, early onset stroke, early onset coronary artery disease as well. So a quick word on cascade screening. This is a concept that was introduced in the 2022 guidelines, and it's defined as the process of extending genetic testing and imaging to identify asymptomatic thoracic aortic enlargement in individuals who are at risk within a family with a known hereditary thoracic aortic disorder. And that's important, only pathogenic or likely pathogenic variants should trigger cascade genetic testing, not variables of unknown significance. With regards to families that have a hereditary thoracic aortic disorders, but don't have a known pathogenic variant, they should still undergo screening with aortic imaging. And this is a class 1 indication. If the imaging is negative in family members, then imaging can be repeated every 5 years for younger family members and every 10 years for older family members. But the guidelines are not very specific as to what they mean by an older family member with regards to age cutoffs, like what is an older patient in this specific situation. So in families where we don't know the pathogenic variant, clinical data is all the more critical because this is our best and pretty much only guide to help us with surveillance strategy. So relevant data that clinicians should collect includes, for example, location of the aortic dilation. Is it more in the root, in the ascending aorta, in the descending thoracic aorta? Also, aortic diameter at the time of surgical repair or at the time of aortic dissection. Sometimes patients don't have a family history and don't have a pathogenic variance. So in these cases, there is still a class 1 recommendation to perform screening aortic imaging in their first degree relatives. Lastly, for patients with an acute type A dissection, it's really important for clinicians to clearly document the diameter of the aorta at the time of dissection, because this can subsequently inform management of their affected relatives. Something to note, after an aortic dissection has occurred, if it's in the aortic root, the diameter of the aorta once dissected is fairly representative of the diameter before dissection, because the root is not too much distorted by the dissection, whereas this is not the case in the ascending aorta, which tends to acutely enlarge after aortic dissection. All right, so now we will move on to surgical considerations for non-syndromic HTAD and for patients with no identified genetic cause. The decision on timing for surgical repair in these patients requires shared decision-making, and should be informed by the aortic diameters of family members when they either underwent surgery or suffered from an aortic dissection. When that information is not available, and if the patient doesn't have any high-risk features for adverse aortic events, the threshold that is now recommended for this group of patients is 5 centimeters. By high-risk features, we mean family history of an aortic dissection at a diameter less than 5 centimeters, family history of unexplained sudden death at age less than 50, and rapid aortic growth, which is defined as 0.5 centimeters per year or 0.3 centimeters per year in 2 consecutive years. Moreover, there's a class 2A indication for aortic repair for patients who have a maximal aortic diameter of 4.5 centimeters, high-risk features of aortic events, or patients who are undergoing concomitant cardiac surgery. This surgery should be performed in an experienced multidisciplinary aortic team. Now we will briefly address some specific syndromes and the specific recommendations for each of them, starting with Marfan syndrome. So we talked about it at length with Dr. Richer, but Marfan's is an autosomal dominant syndrome caused by pathogenic variants of the fibrillin 1 gene. The modified Gantt criteria are used for diagnosis. And in Marfan's, the vascular aneurysms are typically located in the aortic root, most commonly, and followed by the ascending aorta, with the distal aorta being less commonly affected. With regards to diagnosis of Marfan syndrome, every patient should undergo a transthoracic echocardiogram both at the time of initial diagnosis and 6 months thereafter to determine the rate of aortic growth. If the ascending aorta or the root are not well visualized on echocardiogram, then a CT scan or an MRI should be performed to assess the aortic size. With regards to imaging after cardiac surgery, surveillance should be done by MRI or CT scan to evaluate the thoracic aorta, so the arch and the descending thoracic aorta. That should be performed annually, and once it's, if the diameter is normal or if there is no change after 2 years, then surveillance can be done every 2 years. A quick word on medical therapy for Marfan syndrome. There is a class 1 recommendation to treat these patients with either a beta blocker or an angiotensin receptor blocker to reduce the rate of aortic dilation. And there is a class 2A recommendation with regards to combining both medication classes for blood pressure management. There's been a few studies on that topic, and beta blockers and ARBs have been shown to reduce aortic growth rate and clinical aortic events in multiple cohort studies. There's also been 2 randomized control trials comparing beta blockers and angiotensin receptor blockers in Marfan syndrome, and there was no difference between the 2. In addition, there was a recent meta-analysis by Al-Basha and colleagues that confirmed that combination therapy may further slow aortic growth rates. The recommended aortic size threshold for patients with Marfan syndrome is 5 centimeters, which is the same threshold as in the 2014 CCS guidelines. This is based on a landmark report by Silverman and colleagues from 1995, which showed that the life expectancy of patients with Marfan syndrome is markedly improved once they undergo elective cardiac surgery as opposed to emergent cardiac surgery, which is not surprising at all. Since that landmark study, there's been multiple high-quality cohort studies that have shown that the risk of aortic dissection increases when the aortic diameter is over 5 centimeters in Marfan syndrome, despite appropriate medical therapy and lifestyle modifications. Surgery of the aortic root and ascending aorta is reasonable, so class 2A recommendation at a diameter of 4.5 centimeters. And this is when it's present in conjunction with increased risk of an aortic event. By increased risk, that includes a family history of aortic dissection, rapid aortic growth, diffuse dilation, and also marked vertebral arterial tortuosity. As well, clinicians should take into consideration some patient factors, for example, desire for pregnancy and patient's preference. In the 2022 guidelines as well, there's a recommendation which is new from this iteration of the guidelines regarding the cross-sectional area to patient height ratio. If this ratio exceeds 10, then there is a class 2A recommendation for proceeding with aortic surgery. Lastly, with regards to proceeding with a valve-sparing root replacement in a low surgical risk patient with Marfan syndrome, There is a Class 2B recommendation as long as it's performed by an experienced surgeon in a multidisciplinary aortic team. With regards to the distal aorta, so distal to the ascending aorta, the size threshold for surgery is 5 centimeters. This is a 2A recommendation. In patients with Marfan syndrome, there is a risk of ongoing aortic dilation even after elective root and ascending aortic replacement. Patients with Marfan syndrome are also at 10% risk of type B aortic dissection. All right, so we will move on to Loeys-Dietz syndrome. So a quick word on Loeys-Dietz syndrome. It's characterized by aortic and branch vessel aneurysms and dissections, as well as arterial tortuosity and skeletal deformities, which we again reviewed with Dr. Richer. And it's caused by 5 known pathogenic variants, which are listed in red here. We have the most information by far on genes TGFBR1 and TGFBR2. With regards to surveillance imaging in Loeys-Dietz syndrome, patients should undergo, just like in Marfan's, they should undergo a baseline echocardiogram followed by a 6-month echocardiogram to determine aortic growth rate. And after that, patients should undergo annual echocardiogram thereafter. As well, patients with LDS who have a dilated or dissected aorta or arterial branches in their baseline imaging, they should undergo annual CT scan or MRI for monitoring. And lastly, because Loeys-Dietz syndrome can affect pretty much any arterial vessel from intracranial vessels to the pelvis, patients should undergo a baseline imaging from the head to the pelvis, either with MRI or CT scan. With regards to medical therapy in Loeys-Dietz syndrome, there is much less data than in Marfan's, but there is a Class 2A recommendation to use either a beta blocker, an ARB, or both to control blood pressure. This data is largely based on either mouse models of Loeys-Dietz syndrome or Marfan syndrome. Now we can talk about surgical thresholds for Loeys-Dietz. So the thresholds for LDS should be informed by specific genetic variants, the 5 genetic variants that I presented. They should also be, surgery should be dependent on aortic diameter, growth rate, severity of extra aortic features, family history, and patient preference as well. Here's a table directly from the guidelines where you can see the surgical thresholds for Loeys-Dietz syndrome specific to each of the 5 genes that we know. And so you can see that even for TGFBR1 and TGFBR2, the threshold is different whether or not there is presence of high-risk features. In this specific case, high-risk features include a growth rate of 0.3 centimeters per year, a family history of aortic dissection, and very severe aortic features. Quick word to compare the 2010 guidelines and the 2022 guidelines with regards to Loeys-Dietz. You can see that the surgical thresholds for Loeys-Dietz have changed, and nowadays they are dependent on the specific genetic variants and on the presence of high-risk features, whereas before in 2010, the surgical threshold was mostly relying on the imaging modality used to assess the aorta. All right, so we'll talk about vascular EDS. It's caused by a pathogenic variant of the gene called 3A1. And vascular Ehlers-Danlos is characterized by spontaneous aortic and arterial dissections, aneurysms, and ruptures, sometimes at very young ages. And that may occur without any previous dilation. There is not enough data currently available to provide us with a specific size threshold for prophylactic surgery. And these patients were initially thought to be extremely high risk for surgery because of their very friable tissues and risk of bleeding and aortic rupture. So nowadays, shared decision making with the multidisciplinary aortic team and the patient should be at the basis of decision with regards to proceeding or not with surgery. All right, so for Turner syndrome, it's present in 1 in 2,500 live-born females, which is fairly common, I think, relatively speaking. And Turner is caused by complete or partial loss of the second X chromosome, either in all or some of the cells of an individual. About half of the patients with Turner syndrome have cardiovascular defects, and these patients are at increased risk of aortic dissection, which may occur at smaller aortic diameters than the general population. And this is largely due to these patients' short stature. So because of that, using the aortic size index to monitor aortic size is recommended for Turner's patients. And as you will see, the size thresholds are expressed through the aortic size index rather than just aortic diameter. So with regards to recommendations on diagnosis and surveillance, patients with Turner syndrome should undergo baseline TTE and cardiac MRI at the time of diagnosis. The reason for cardiac MRI is to evaluate for concomitant congenital anomalies. For example, bicuspid aortic valve or anomalous aortic root anatomy. When the patients reach age of 15 years old, the use of the ASI, so aortic size index, which is defined as maximal aortic diameter in centimeters divided by BSA in squared meters, should be used. And patients who do not have risk factors for dissection, which are listed here in table 12, so aortic coarctation, dilation, BAV, or hypertension. In these patients, they can go surveillance imaging every 5 years in children, every 10 years in adults, and right before pregnancy. And lastly, patients who have an aortic size index of 2.3 or more should undergo imaging at least every year. In patients with Turner syndrome over 15 years of age, the frequency of aortic monitoring depends largely on the presence of the high-risk features I presented and on the aortic size index. So you can see in this figure that the recommended frequency ranges from 5 to 10 years on the far left to every 0.5 to 1 year in very high-risk groups on the far right of the screen. With regards to surgical thresholds for Turner syndrome, surgery is recommended as a Class 2A recommendation in patients who have risk factors for aortic dissection and an ASI of 2.5 or more. In patients who don't have any high-risk features, the recommendation is a class 2B for surgery if they have an ASI of 2.5 or more. Why do we use an ASI of 2.5 in Turners? This number is derived from data from several registries of aortic dissection in Turner syndrome, in which the risk of aortic dissection was markedly increased at 2.5. A quick word on other pathological or likely pathological variants. So this is again a table from the guidelines document showing that the decision regarding the timing of aortic repair in non-syndromic HTAD is based on many factors. It's based on aortic diameter, of course, but also age, family history, and the presence or absence of additional risk factors. Here you have specific size thresholds for some specific gene variants, ACTA2 and PRKJ1. I will spend the next few minutes talking about bicuspid aortic valve aortopathy. So as many of us probably already know, about 1% of the population has an aortic bicuspid aortic valve, and BAVs are found in a male to female ratio of 2 to 3 to 1. Most often, BAV is sporadic, but it can sometimes occur in an autosomal dominant pattern. And it's either isolated or associated with congenital cardiac defects, such as anomalous coronary arteries and with aortopathy. All patients with bicuspid aortic valves should undergo a transthoracic echocardiogram. They should also undergo a CT scan or MRI of their thoracic aorta. Especially if the transthoracic echocardiogram cannot reliably measure the aortic size. If the patients have BAV, but also have phenotypic features concerning for hereditary thoracic aortic disorder, for example, Loeys-Dietz syndrome, then they should be referred to a medical geneticist, and this is a class 1 recommendation. All first-degree relatives of patients with a BAV and a dilated aorta should undergo a transthoracic echocardiogram. This is a class 1 recommendation. And in patients who have a bicuspid aortic valve but a normal aorta, there is still a class 2A indication to screen all their first-degree relatives with the transthoracic echocardiogram. With regards to monitoring, whether or not patients with a bicuspid aortic valve have undergone surgical aortic repair, surgical repair of their aortic valve or surgical replacement of their aortic valve, if their aortic root was at least 4 centimeters in size, they should undergo lifelong surveillance imaging, because in these patients, progressive aortic growth may occur even after the bicuspid aortic valve has been replaced or repaired. This is coming from a few clinical studies. More specifically, there was a series by McKellar and colleagues of over 1,200 patients who underwent an isolated aortic valve replacement for bicuspid aortic valve. And in this study, the 15-year freedom from aortic events, that is dissection, aneurysm over 5 centimeters, or need for aortic aneurysm surgery, was 89%. However, that the freedom was much lower in patients who had a baseline aortic dilation as opposed to those with normal aortic diameters at baseline. That is 85% freedom versus 93% freedom. And this was statistically significant. As well, in a meta-analysis fairly recent from 2015, that looked at patients with bicuspid aortic valve who underwent isolated AVR for aortic regurgitation or aortic stenosis. They found that patients who had a predominantly regurgitant aortic valve lesions were at higher risk of late aortic dissection than those who had a baseline aortic stenosis. And the so-called aortic root phenotype, that is aortic regurgitation primarily due to aortic root dilation, confers an overall higher risk of long-term aortic events. Moving on to the intervention recommendations for bicuspid aortic valve aortopathy, the size thresholds in the 2022 guidelines is 5.5 centimeters. Also new in the 2022 guidelines compared to 2010, there is a mention of the cross-sectional aortic root or ascending aortic area to height ratio. If this number is over 10, then there is a class 2A recommendation to proceed with aortic surgery. Where does 5.5 come from? This is derived by several retrospective studies. A study from Zafar and colleagues from Yale University was conducted with a large number of patients, 780 patients specifically with thoracic aortic aneurysms. And the group looked at growth rates, yearly complication rates, and survival in patients with thoracic aortic disease. They performed a risk complication analysis using logistic regression, and that revealed that the risk of an aortic event increases sharply between 5.25 and 5.5 centimeters, and then again between 5.75 and 6 centimeters. For patients with a bicuspid aortic valve who undergo a concomitant aortic valve repair or replacement, the size threshold for the surgery for them should be 4.5 centimeters, as long as the surgery is performed by an experienced surgeon in a multidisciplinary aortic team. For patients with an aorta between 5 and 5.4 centimeters, if they have an additional risk factor for aortic dissection, which are listed here in table 14, there is a class 2A recommendation to proceed with a surgery. Something to note, another change compared to 2010 is the definition of high or a rapid growth for bicuspid aortic disease. Back in 2010, it used to be 0.5 centimeters per year, whereas now for bicuspid aortic disease, anything above 0.3 centimeters per year is significant. Lastly, for bicuspid aortic valve aortopathy, when a patient is low risk for surgery and has a diameter between 5 and 5.4 centimeters and no other risks for dissection, there is a class 2B indication to proceed with surgery. Here is a quick summary table with the size thresholds for surgery pre-pregnancy. As you can see, they are divided by specific hereditary thoracic aortic disorders, and as well, Marfan syndrome and Loeys-Dietz syndrome have different thresholds depending on the presence of high-risk features. And for Loeys-Dietz syndrome, the size threshold is also dependent on the specific pathogenic variants. So that's also some progress in the new guidelines. So I will conclude briefly by pointing out some more of the differences between the 2010 and 2022 ACC and AHA guidelines. In the 2022 guidelines, the surgical thresholds are now adjusted by patient genetics, patient sex, and patient height, which is much more specific than before. Also, while in 2010, aortic imaging was recommended only for relatives with a known genetic mutation, now imaging is recommended in all first-degree relatives, even if genetic testing did not reveal a a pathogenic variant. Lastly, there's a class 1 indication now for genetic counseling and genetic testing for the management of hereditary thoracic aortic disorders. So in conclusion, in the 2022 guidelines for genetic aortopathy, multidisciplinary aortic teams and a shared decision-making approach are at the core of the management of these patients. We now have access to increasing amounts of data on the genetic etiology and on the clinical implications of hereditable thoracic aortic disease, which have now resulted in fairly specific recommendations for particular syndromes. However, there remains many gaps of knowledge and many areas of potential future research. For example, in vascular EDS, where we don't have enough data for specific thresholds. In the future, we hope to see more diversified patient populations represented in the literature with more sex-based recommendations as well. We also anticipate the discovery and implementation of new biomarkers, for example, proteins or non-coding RNAs, as well as implementation of biomechanics in testing and in prognostication of thoracic aortic disease. And lastly, but not least, living with a hereditary thoracic aortic disease has been shown to significantly affect quality of life of patients and their family. And we anticipate more and more data on patient-reported outcomes, which will hopefully also further guide management on heritable thoracic aortic disorders. Here are my references, and thank you everyone for your attention today, and I'm looking forward to more discussion.
So does anyone have any questions for Kenza? Lillian.
Hi, Kenza. That was excellent. Such a great review of a lot of info. My question to you is because I'm a pediatric cardiologist and I have a severe Marfan's patient, neonatal Marfan's, and I wanted to know in your research for this talk, did you come across any information on surgical thresholds for operating on neonatal Marfan people or children at least? You know, where the measurement of 4 centimeters in a baby is really big compared to an adult, and we certainly don't intervene at that number. But just want to know if you've come across anything for pediatrics at all.
Yes, so thank you so much, Dr. Lai, for your question. Absolutely, 4 centimeters is probably bigger than a neonatal heart. So there is the Z-score, which is used for patients of smaller size and especially in children. I'm trying to look up if there is a specific threshold for Marfan syndrome. I do not remember it on the top of my head, but maybe Dr. Richer, if you know more than me for pediatric patients, I can try to look up the answer for you, Dr.
Not one, actually.
So the reason
There's no
the,
threshold.
the,
Maybe
the
that's
reason why
done, you know? That's a study waiting to be done in pediatrics, I think, if we haven't come across it yet. Yeah. I don't know, Julie, have you
Yeah,
heard
I
of
was
it?
about to say that the reason why you ask that question is that dissections are quite rare in pediatrics, but rare doesn't mean that they never occur. And what I've heard is, if possible, wait until the child is old enough to accommodate, not old enough, until the annulus is big enough to accommodate an adult size graft, if at all possible. But I agree with you, Liliane and Kenza. It is like the Pandora's box of every clinician when you see a very severely affected child is what is in the best interest of this patient and what might do more harm than good, and when to actually get to something that is more invasive once they're because some of those patients that are extremely severe, despite maximizing a dual pharmacotherapy, they will continue to dilate. And we get even more worried in boys, particularly when they're approaching puberty, because we know that this is when the risk of dissection will increase. So that's always the $1 million question.
Males are at higher risk approaching puberty, just out of curiosity.
Why males? Because we know that in general, for aortopathies, male are at higher risk of events at a young age. So that's also true when you make them younger. So Kenza, you did a phenomenal job. Thank you so much for presenting all of this. And I see that Munir has been able to join us. Thank you so much, Munir, for joining us after what I'm sure was a pretty busy day in the OR. So thank you for being here.
Yeah, sorry everyone for joining in late. I was actually dealing with the consequence of the problem that we're here to talk about, which is aortic dissections and aortopathy. So unfortunately, I had to take some time to take care of the case. But Julie, fill me in on where we're at and if you how I can contribute here.
So thank you so much. So I gave like a general overview, and then Kenza presented the AHA guidelines. So that's great. And we just got one question in the chat asking, while not define expert opinion on age at which it is okay to back off to 5-year surveillance for first-degree relatives of gene-negative non-syndromic HTAD after adolescence or older. So that's a multi-part question, Ryan, and we'll do our best to all chime in to answer you. So depending on who you read, so the European guidelines will say that you start screening at 25 years old or 10 years prior to the youngest aortopathy in the family, which of course is always difficult if somebody presented with a dissection, because you know that they started dilating much before for most genes. So that's when you start. When there's a severe phenotype for non-syndromic, so we're not talking about the gene management guideline that Kenza just talked to you about. So if people all presented well in adulthood, until you won't start screening them until about 2025, partly so that they have time to get their life together, get their insurance together so that they're insurable and can build their life. And then you will screen them ongoing. And initially a little bit more frequently, and then if it stays normal, then you go to the 5 years. The guidelines say until 65 years old. That may not be true for a family where you have people who first presented at 65 or 70, in which case you may do a few other echocardiograms or imaging, depending on the area you're looking for. I'm not sure if that answers your question, and Munir and Kenza, if you have anything to add to that comment in the chat. So Ryan, does that answer your question? Sorry? Ryan, does that answer your question?
I guess
Thank
the
you.
one other comment is we're talking about gene negative hereditary thoracic aortic disease. The question that comes to my mind is, when did the proband manifest with symptoms? So we have seen in our experience, a handful of cases where a patient who's in their 70s presents with an aortic event, and then we learn later that there is a family history of aortic disease. The family members themselves are unaffected phenotypically, so completely normal aortic imaging. And the question is, what's going to be our surveillance protocol, and how long are we going to do this? And I guess I don't know, Julie, if you have this experience, or if you would say something differently here, but if the proband is older when they manifest with the aortopathy, I suppose that changes what you do, right?
If the proband and everybody else in the family, so it will always be who is the youngest in the family, and often when the proband is younger, the other piece of this is that their first degree relatives are often already past 25 years old, right? Because if you diagnose somebody who's 65, their kids are probably already 35 or 40, in which case you will probably start to screen them. The other thing I was thinking of as we were debating this and talking about this is, we said gene negative non-syndromic HTAD. What we didn't spend a lot of time talking about is that the list of genes that are available for testing is an ever-changing target. So despite the fact that if fibrillin 1 accounts for about 50% of what you'll find any day of the week, if your patient was tested like 10 years ago, that is probably something where you may want to get their proband reassessed if it has significant clinical implication. Same thing if you had a VUS in the family, those VUS need to be reassessed. We know that the classifications of variant changes, and particularly in the cardiovascular field, there's been a lot of classifications that have changed. So if what you have is a VUS, like Kenza told you, that's not something you use for predictive testing, but you need to make sure that it's still a VUS today, not just when the testing was performed. Munir, does that answer what you were alluding to?
Yep, perfect.
So home stretch, Munir has done fantastic work with the Titan trial, and I personally learned a lot when he educated me about this, and I hope that you will learn just as much as I did. He's a fantastic speaker, so enjoy.
Okay, excellent. So thanks, Julie, for that introduction, and again, apologies. Julie, I want to do a quick time check. I know I joined late, so what kind of time do I have?
About an hour, Munir.
Okay, I'm definitely not planning to take that long, so we'll hopefully have some time for conversation afterwards.
In theory, your hour is 45 minutes plus 15 minutes of conversation, but conversation is always welcome.
Perfect. Excellent. With me presenting, I'm not able to monitor the chat. I'm happy to stop and take questions midway. So, Julie, if you see anything in the chat that's worth stopping and discussing between the presentation, please feel free to stop me. Okay, so I'm going to be talking a little bit about something that's not really rare disease, genetic aortopathy type of stuff. It's more the big picture of what we tend to see in the world of aortic disease, aortic medicine. I'll talk about the clinical problem, what we know, why we have felt that we need a clinical trial to address some of the challenges that we have. We talk a little bit about design considerations, practical issues, and some of the future directions that we have. So this is a very common scenario. A 42-year-old male construction worker presents to the emergency department with atypical chest pain. He's physically active, doesn't really have a lot of risk factors except for borderline hypertension. He's a former smoker, nothing contributory on exam. And then he has this transthoracic echocardiogram done because of this atypical chest pain, and it shows an aorta of 53 millimeters at the ascending aortic level. It shows an aortic root that's moderately dilated at 41 millimeters. There's a trileaflet aortic valve. There's no stenosis. There's mild regurgitation. The gentleman has a normal ejection fraction. So this permutation occurs quite commonly. The question is, what do you do in this context? And I'll just let the audience kind of think about this. You don't have to actually answer, but you feel free to offer up your answers in the chat as well. We could start a beta blocker. We could refer for aortic replacement because we feel there's a sufficient criteria to do so. We could order another imaging study, a CT or an MRI, and if concordant, refer for surgery. We could initiate annual surveillance, thinking that this does not require intervention right now, or we could do none of the above. Linked to this question is the notion of risk in this patient, and what is the natural history risk of aortic complications or death in this patient? Is it less than 1% per year? Is it 2 to 5% per year? Is it 6 to 10% or 11 to 15% or greater than 15%? And of course, your assessment of the risk, natural history risk, will guide what treatment decision is made for this patient. There's a lot of gray in the literature in terms of predicting this risk, and so that lends some controversy to our decision making. So we know that thoracic aortic disease broadly account for 40,000 deaths in the U.S. Annually. We know that these aneurysms stay largely asymptomatic until some catastrophic event occurs, either a dissection or rupture. We know that mortality and morbidity for patients undergoing intervention with acute aortic syndromes is substantially higher than that for elective intervention, which is why the treatment paradigm of identification, surveillance, and timely surgical treatment of patients at risk. This is just a quick comment to say that the aorta, of course, spans our entire body, and we use different criteria for intervention in different parts of the aorta for obvious reasons, because first of all, the natural history risk is different based on size. The actual normal size of the aorta is different based on its location. And then intervention-related risks are also substantially different based on location. So the operations involving the aortic arch are not the same as operations involving the ascending aorta or a stent graft that's sometimes performed for the descending thoracic aorta. I'm going to talk a little bit about what the surgical view of aortopathy looks like, and we'll just run this video in the background as we do so. So this is your typical patient with Marfan syndrome. You saw at the early part of this video that this is a root aneurysm focused largely close to the aortic valve, but you can see tapering of this aorta or normalizing of its diameter as you get to the distal aorta, the typical pear-shaped Marfanoid aorta that we see. On the left-hand side, you see an echocardiogram showing the same and showing a competent, normally functioning aortic valve. So we see this type of problem not infrequently, and just want to give you a flavor for what repair looks like for this type of problem. We are in this case planning for a valve-sparing root replacement procedure. And what that involves us doing is dissecting out the aortic root, which is really at the center of the heart, and detaching it from its surrounding structures. And doing so enables us to free up the entire aortic valve. Now, I think one thing to realize is that the surrounding structures do present a bit of a limitation into how much of the aortic root can be completely dissected out and isolated and replaced while preserving the aortic valve. And so in this case, in this region of the aortic root, we're able to dissect it out completely down to the level of the leaflet insertion. However, in other parts of the dissection that you'll see, the aortic root is not able to be fully isolated. Here we've dissected out the right coronary ostium, and now dissecting out below that, this is the region of the membranous septum. And we see that transition point between the aortic wall to the membranous septum. And then we continue our dissection down to the level of the leaflet insertion on the right coronary cusp. Similarly, we'll now detach the left coronary button and then dissect out the aortic root. I'm only going to show some elements of this video just to give you a flavor for what the final product looks like. But we now have dissected out most of the aortic root. This is the right-left commissure. And once this dissection is done, you'll see that the valve gets freed up completely from its surrounding structures. And what this enables us to now do is to use a graft that goes around the aortic root down to the level of the valve leaflets, but essentially allows preservation of the aortic valve while replacing the aortic root. And this is a fairly normally functioning aortic valve. You see nice trileaflet valve coapting in the middle in a symmetric fashion. I'm gonna skip ahead a little bit. This is the Dacron graft that we're going to be employing in this situation. You can see now that the graft has been placed around the valve, and the valve will now be implanted within the graft in a stepwise fashion. And this is that suture line that allows us to reimplant this valve. And we continue. Once this entire valve is reimplanted, we can look at it to see how it functions. In some cases, we have to perform some cusp repairs to enable this valve to work normally. We then go on to implant the coronary buttons. We saw a brief view of that. And now the entire root is intact again. The coronary buttons have been implanted. We connect our Dacron graft to the distal aorta, and that effectively completes this operation. So this type of operation is done quite commonly, and it's the preferred operation in someone who presents with genetic aortopathy like Marfan syndrome. And this type of operation has a very low mortality and morbidity. Patients tend to do well. And the surgical risk for this type of operation is something around 1%. Long-term outcome for this type of operation is well over 20 to 25 years with a well-functioning aortic valve. On the other hand, we see patients who present with acute aortic dissection, like the CT scan seen here, with flaps in the aorta, tears in the intima, and a very bruised-looking aorta, as you see on the right-hand side. This type of aorta, when we are working with this, looks and feels very different than your elective aortic operation that you saw earlier. In this case, there's you can see hematoma in the wall of the aorta. There's a separation of the layers of the aorta, and often patients present in shock. They have malperfusion, and this needs to be dealt with on an emergent basis. We don't often have the right teams available because we're doing this in the middle of the night, and it becomes basically a salvage operation, a salvage consideration. We see the other spectrum of this, which is intramural hematomas, and you can see similarly that it's a much less controlled situation with the hematoma seen between the intimal layer and the adventitial layer. The last piece of this acute aortic syndrome story are penetrating atherosclerotic ulcers, not related to size necessarily, but really due to diffuse atherosclerosis. So acute aortic syndromes are a surgical emergency. They have high mortality. Up to 40% of patients don't make it to hospital. And we know of the 1% per hour mortality rate from hospital arrival to intervention. Even if someone makes it to intervention, they bear a mortality risk of between 10 to 20% and a high risk of stroke, renal failure, myocardial infarction, and a variety of different vascular complications. Knowing this story, our goal is that when someone with a normal aorta presents with an aortic aneurysm, we want to intervene in time to replace the diseased aorta with a Dacron graft in a prophylactic fashion so that we prevent aortic complications. However, the decision-making is not always super simple. Of course, it's a balance between the risks and the benefits. On one hand, we're talking about the natural history risk of having an aneurysm, and on the other hand, we're talking about the intervention-related risks. Consideration is also given to what the normal aortic size is, and we know that aortic size changes with patient size. Their body surface area is one way to index aortic size. This is the classic study that has led to many of the guidelines around management of aortic disease. This shows that as your aortic size increases, so 3.5 to 3.9 being the reference, 4 to 4.9, 5 to 5.9, and greater than 6 in black, your risk of rupture, dissection, or the composite of rupture, dissection, or death significantly increases as size increases. It's important to note that this landmark study that has really informed a lot of our guidelines comes from a cohort of about 800 patients, which was a mixed bag of patients. About 10% had Marfan syndrome, 72% had ascending aortic disease, and others had other types of aortopathy. And in total, 92 endpoints were achieved in this study. And so really a lot of our thinking around this is formed from this data from Yale, and it's a large data set, but it's still single center with its significant limitations. This is another publication from the same group showing a graphical representation of increasing risk of rupture, dissection as the size increases, with an inflection point somewhere between 5 and 6, and definitely a increase in size, increase in risk after 6 centimeters of aortic size. All right, so knowing this information, what do I do as a clinician or as a surgeon? I'm trying to look at the patient in front of me and try to tell them on one hand, on the right-hand side, for example, what is the natural history risk of this disease? So if I don't operate, what will be the risk of dissection and rupture? And if someone dissects, what is their risk of surviving that dissection? So what is the mortality risk associated with that? And on the left-hand side, I am looking at what are the intervention-related risks. And of course, these are tailored to every single patient. So a patient with other comorbidities will have a higher intervention-related risk. Someone with familial aortopathy or genetic aortopathy will have a higher natural history risk. And so on the left-hand side, I'm talking to my patient and telling them about 1% risk of surgical mortality. And on the right-hand side, I'm thinking about a 5% per year risk of acute aortic syndrome. And if they have an acute aortic syndrome, there's perhaps a 50% chance that they won't survive it. And weighing those mortality risks, I arrive at a recommendation and I tell them, yes, you should have surgery to fix your aorta, or maybe you shouldn't have surgery and maybe you should continue with surveillance. What we have more difficulty incorporating is what is our risk of morbidity? What is my stroke risk with my intervention that I'm planning? What is the risk of stroke or vascular complications if they have a dissection or a rupture? And I can make some estimates of that. However, the story is even much more complex than that. What about reintervention rates? If I operate on someone at the age of 30 years old because they have aortopathy, what is their lifetime risk of reintervention? What about their aortic valve and the preservation of the aortic valve? Will they require valve-related interventions in the future? Will they have valve-related complications in the future? Ultimately, what is their impact on the quality of life? And what is going to be the impact on their vocational choices, et cetera? And so, as you can imagine, when you have a patient in front of you, the studies that we currently have that simply speak to the mortality risk or the acute aortic complications risk don't really do justice to all of the gamut of issues that each patient struggles with as they're making these decisions. And add to that this notion of a one-time risk with intervention versus an annual risk with natural history or follow-up. Sometimes patients have difficulty equating the two. 1% versus 5%, is very different if you're talking about an annualized risk versus a one-time risk. And finally, the patient's values and preferences in terms of what they wish in their life is of course an important consideration. Okay, I'm gonna move forward. What kind of throws a bit of difficulty in our decision-making is this data from the IRAD registry, the International Registry on Aortic Dissection, which showed basically that the mean diameter at which patients dissect is 5.3 centimeters. So using a guideline-based surgical threshold of 5.5, we are likely to miss more than half of the patients that are going to present with acute type A dissection. Now, we can further nuance our decision-making and use lower thresholds like 5 centimeters for certain familial aortopathy or patients with certain risk factors, but that still misses a large group of patients that have a risk of type A dissection. Having said that, we've seen this in our clinical practice that diameter is a very crude measure of risk. I have seen this patient with a very large 9.5 centimeter undissected aneurysm in an elderly female, and you can see the very small descending thoracic aortic diameter aorta in comparison. And on the other hand, we've seen intramural hematomas occur in a 3.5 centimeter aorta. And so when we simply make decisions based on diameter, we make decisions based on incomplete information. There are non-diameter related criteria that we try to incorporate in our thinking. We try to adjust for sex or age or family history. We sometimes index our measurements, even though the evidence base for that is not very robust. We try to incorporate symptoms and associated conditions. There's an important body of study from a number of groups, but particularly Dr. Coutinho in Ottawa, who's looked at aortic characteristics like stiffness and compliance and its impact on aneurysm expansion. There are other imaging characteristics like aortic length, different imaging indices like cross-sectional area, height, wall thickness, and wall stress. And then there's the ever-increasing promise of biomarkers as a potential predictor of aortic syndromes, although this is far from being realized. So with this background, we ventured out to try and design a clinical trial to help us inform decision-making in aortic disease. We started off with a particular clinical question. You can imagine that the number of questions you can ask about this population is quite large, but we wanted to start the process somewhere and make a compelling case to our granting agencies to fund a clinical trial. So the reason for the clinical trial are really threefold. There are ambiguous guidelines, there's lack of quality data, and there's evidence of clinical equipoise. The first aortic guideline statement was released in 2010. This was a multi-society statement. They made 79 different recommendations. 60% of these were Class C or consensus-based recommendations. There was only one Class A recommendation in this entire guideline for the full spectrum of management of aortic disease. Fast forward to 2014, 70 recommendations made in the European guidelines. 86% of these were Class C, no Class A recommendations. However, independent investigators like the folks at Yale continue to push the envelope. Their most recent publication suggests that we should have a further leftward shift in aortic aneurysm thresholds to 5 centimeters instead of 5.5, because in their data set, they see a hinge point occurring somewhere between 5 and 5.5, perhaps around 5.2, and this suggests to them that we should have a leftward shift. We conducted a systematic review and a meta-analysis to better understand what data existed prior to the design of our trial. And we basically found, interestingly, that when we looked at 20 studies of about 8,800 patients, about 32,000 patient years of follow-up, we found that the average growth rate of aneurysms was quite small, and the risk of complications of dissection, rupture, or death was also not super high at 2.2% per year. This was a somewhat smaller size patient cohort, so mean aortic diameter in this meta-analysis of 4.3 centimeters. Interestingly, though, if you look at this this dot on the top right-hand side with the red circle, this is somewhat of an outlier in terms of the risk of mortality and complications. This is the Davies publication that we discussed earlier from the Yale group, which seems to be an outlier in terms of the size-based risk of dissection and rupture. Our conclusion from this was this meta-analysis was that the growth rate of ascending aortic aneurysms is slow, and the risk of dissection and rupture is probably lower than we previously understood. However, a randomized controlled trial is needed to really understand the number needed to treat in order to justify the risk of intervention to our patients. We conducted a contemporary survey of 700 clinicians, a mixed bag of clinicians, including cardiologists and vascular surgeons and cardiac surgeons. And we really found that despite the guidelines stating that we should operate at 5.5 centimeters, when you ask someone, what do you do for your typical patient who has no significant risk factors, about half of the population replied that they would operate at 5 centimeters, and the other half said they would operate at 5.5 centimeters. So with that in mind, we went on to design the Titan SVS clinical trial, and this slide basically summarizes what this trial is. What we're doing is taking patients who have aortic size between 5.0 and 5.4 centimeters. If they have 5.5 centimeter diameter, then they meet criteria for intervention based on current guidelines. We actually exclude patients who have familial or genetic aortopathy, rapid aortic growth, who have symptoms, who have complex aortopathy, including the descending thoracic aorta, who have other non-aortic indications for surgery, and who are otherwise unfit for surgery. And we then randomize them to either having surgery or to have ongoing surveillance on an annual basis with ultimate intervention if they grow to a size of 5.5. Patients enrolled in the trial have optimal medical therapy, control of hypertension, smoking cessation referrals, standardized imaging, usually annual CT scans, and follow-up of up to 5 years. The primary endpoints of this trial are all-cause mortality, and secondary endpoints include a variety of different outcomes, including acute aortic syndrome, 30-day mortality, incidence of elective aortic surgery, stroke, aortic growth, and quality of life. The patients who are excluded by virtue of their exclusion criteria or by patient refusal are included in a registry. And we're actually really excited about how this registry is growing over time because it gives us the first prospective multi-center look at the natural history of aortic disease in a mixed population. The sample size for this randomized trial is 618 patients. We had hoped to recruit over 3 years, but this annoying thing called COVID got in the way, and we are much slower than our anticipated recruitment, but continuing to increase over time. Another important element is that we have both an imaging core lab with CT scan downloaded into a core lab that will be analyzed in a standardized fashion, as well as a biobank that we're slowly growing in patients who are either in the registry or RCT arms of this trial. We struggled with a lot of issues in design of this trial. This is the first of its kind in ascending aortic disease. Our colleagues in vascular surgery have already done a trial of surgery versus surveillance in abdominal aortic aneurysms. But in the ascending aortic domain, this is the first of its kind. And some of the issues we struggled with is trying to design the optimal primary endpoint, which needed to be specific which needed to be clinically important, unambiguous in its assessment, and measurable. From a sample size consideration, we struggled with the early hazard in the surgical group, so the mortality risk associated with intervention, versus the late hazard that is anticipated in the medical or the surveillance group, and considerations around our curves crossing over time, and of course trying to design around the anticipated rates of accrual and follow-up. Some practical issues that we've run into, we all are familiar with a large, or we see in our practices perhaps a large group of patients with aortas between 5 and 5.4, but due to a variety of considerations, a number of people are not trial eligible. Even those who meet trial eligibility criteria, in the clinician's mind, sometimes are not appropriate for randomization. The very young patient, even though they don't have a documented genetic aortopathy, one might lean towards earlier intervention. On the other hand, the comorbid patient or the morbidly obese patient may not be appropriate for randomization to surgery. And so the number of patients that meet the clinician's threshold for clinical equipoise gets smaller and smaller. There are patient perceptions around autonomy, their willingness, their desire to make their own decisions about this important decision, the fact that it's a high stakes decision, the need to seek out the expert's advice, who in front of them tells them, well, I don't really know the answer, and then you should participate in a trial. There's a notion that stability is protective, although there's no data to support this. And then intercurrent issues that are often diagnosed in the context of aortic aneurysm. We talked a little bit about impact of COVID and suspension of research, the need to shift to a virtual paradigm for this type of trial, and need for multiple protocol amendments that has hampered us a little bit. But over the last 5 years, we've grown this Titan program, which started off with this single clinical decision question around randomized trial for 5 versus 5.5. This has now grown to a large registry, which will hopefully give us some new insights into the natural history risk, including considerations of quality of life in this population. We have a core imaging lab that will hopefully allow us to identify new imaging-based risk predictors of events in this population. And we are growing a biobank that will hopefully allow us to explore the role of biomarkers in predicting risk. This represents a recent snapshot of where we're at. The number of randomized patients actually has grown to around 145 or so, 143 maybe, and the registry has now over 200 patients in it. We steadily accrue patients, but are still looking to grow this in an exponential fashion if we're going to actually achieve completion of this trial. To date, there are 20 sites now activated, and we have currently about 2 million in funds from CIHR and other sources for the study. It's taken a while for us to get to this stage, and there's been some slow growth and growing pains. And what we're hoping is that in partnership with all our collaborators, we've now developed this infrastructure, both for trial coordination, a certain degree of commitment in studying aortic disease in a more robust fashion, ability to design new trials in an innovative way, and with pilot funding, we're actually leveraging this network for other clinical trials in aortic disease. There are 2 additional trials, mainly focused on surgical treatment of aortic disease, how we manage aortic dissections, what kind of temperature we use for aortic arch surgery, etc. But there is a potential for growth into the medical side of aortic disease as well, impact of blood pressure control and other risk factor management in the natural history. And ultimately, our holy grail is really to go from this randomized trial data to personalized medicine, so that when the patient walks into a clinic with an aortic size of 5.0 or 5.2, we don't just make a size-based decision on this patient, but we actually personalize the decision based on other unique elements of their presentation, their imaging, and potentially even some biomarker profile that they have. None of this is possible without a very large group kind of behind us. And so this slide refers to many of our site PIs, our funding partners, as well as our statistics, core imaging lab, and our biobank team. I'm going to stop here and open it up for any questions.
Thank you so much, Munir. Great talk. Lillian has a question.
That was great, Munir. Really enjoyed it, and I think I hear you talk. I've heard you talk about this before, but there's so many details, and it's such a big trial. I had a question about bicuspid aortic valve. Is that included in your familial aortopathy? I guess not really, but like I would only assume a majority of your patients have that, and I guess you'll be analyzing the data based on if they have that or not, and how many patients so far have a bicuspid aortic valve? It's such a common thing.
Yeah, it's a great question. Yeah, so non-familial bicuspid aortic valve aortopathy is included in this trial. For some of the reasons you mentioned, you know, the guidelines have kind of the pendulum has swung a couple of times on this, but the current thinking is really that we should treat it as trileaflet aortic valve unless there are red flags like a family history of an aortic event. So yes, they're included. What percentage? I actually don't have that handy, but I can tell you from my personal experience that probably in the range of 30% will be BAVs. So I think what we hope to do is, you know, at the end of this, be able to look back and analyze on whether the natural history or the outcomes or our thresholds should be different between BAVs and non-BAVs.
If nobody else has a question, I'm curious, Munir, how many have, you said about 20% have BAVs. How many would have the root involved versus only descending? And the reason why I'm asking is that we still need to run through our stats, but my impression is that detection rate of molecular testing for ascending aortic aneurysm when the root is not involved is really low, like even lower than when the root is involved. So I was curious about your experience, like which patients you see most of.
Yeah, it's, you know, there is a bit of a gray zone there in my mind because when we say root is involved, there's a, you know, how do you define involvement? If I have a patient with an aortic, ascending aortic size of 5.3 and the aortic root is 4.1, is the root involved? Well, you know, it doesn't meet threshold for intervention. It's definitely not normal, but it becomes a bit gray, as you can see. So one way to assess root involvement is to say, well, you know, when a surgeon intervenes, do they replace the root or not? And if they replace the root, presumably it was involved either because how it was assessed at the time of surgery or because of size going into this. I would say the rate of root involvement by that definition is high being, I would say, over 50%, because when we tend to intervene, one would have to have a pretty high threshold to leave aortopathy behind when you're, you know, operating on a patient. So yeah, anything that is in the 4.3, 4.4, 4.5 range will tend to get intervened on. And many patients have that if their ascending is already upwards of 5.
So you'd say that about 50% will have that if their ascending is upwards of 5.
Yeah, so this is not from the trial data, I should say. We haven't actually analyzed it, but this is my personal clinical experience that when we operate on patients with ascending aortic aneurysms, more than 50% will have some degree of root dilatation that requires a root intervention.
That would fit what I see in my clinic, but you see a more overall representation than I do. And those patients where you will replace the root, I'm more likely to find something. But the ones where you won't even replace the root, the chances are I won't find anything. I'll still try.
Yeah, no,
But I
exactly.
won't.
Exactly. Exactly.
Anybody else has any questions for Munir?
Or we can also open it up for any other general areas that people wanted to bring forward.
Probably have another like 10 minutes together, after which it would probably be good for everybody to stretch their legs before they're supposed to come back at 4 o'clock to meet with the larger group. So anybody who has any question about anything we've talked about or not talked about that is of interest to you, and we'll do our best.
I have a question, Dr. Richer. We talked about variants of unknown significance, and you mentioned that clinicians need to ensure that what used to be variants of unknown significance are still unknown. Do you have any resources that you recommend for non-medical geneticists to try and stay up to date as much as reasonable?
Yes and no. So there are resources. Like what I will check is something like ClinVar and see whether this variant has been reported again and whether other labs have seen it, etc. That's a good start. From your point of view, you're probably better off to refer the patient back, quite honestly. If it's been like that 5 years or something like that, both because we'll recheck the variant, but we'll also check whether the panel itself is still up to date and whether this panel needs to be updated. For some labs will update the variant classification for you, so you could go directly to the lab as well, but it depends which lab currently, and this is something that we are trying to rectify. Currently, labs, at least in Ontario, are not paid to reinterpret your variant. So if people submit requests, they do all of that work for free right now. So it's variant interpretation, though, is not always straightforward.
Thank you, Dr. Richer.
You're most welcome, Kenza.
If there are no other questions, maybe we can let people go and stretch their legs before we go back to the main session. Is that okay, Julie? What do you think?
Absolutely. Thank you so much, everybody, for joining us. We really appreciate your participation, and see you soon.